Okay, everyone. Well, we're very excited to be doing this webinar today. The title, as you can see, is Electronic Health Record with Top Awards is Back and Better Than Ever. So with no further ado, I'll jump in and give you a bit of introduction about ourselves and the webinar, and we'll get things underway today. So we are 1 Million Solutions in Health, and my name is Dawn Van Dam, and I'm the president of 1 Million Solutions in Health. And as you can see, our goal is to help improve healthcare one solution at a time. And we bring these forward in the areas of life sciences, healthcare, and ideas for patients and consumers. And how do we do that at 1 Million Solutions in Health? Well, our goal is to connect to others working on initiatives around the globe to improve healthcare, accelerate life sciences research, and share patient and consumer-focused ideas and solutions. And the way we do that is through events like today's webinar, live events, discussion forums, articles, etc. We put together collaborations and consortiums. We do it all across the industry to help people accelerate the adoption of science. So we would like to encourage everyone who's listening today to send us your ideas, whether you be in academia, government, if you're an entrepreneur or business, and we'll work with you to see how we can share your ideas with our global community of over 5 million members. So to today's webinar, let me give you a brief introduction, and then I will introduce the speakers, and we'll go from there. So today, this webinar will feature Dr. Charles Webster, an expert on healthcare IT workflow and business process management. He will lay out the ABCs of electronic health record workflow technology, going over details on the workflow engine, workflow definitions, and workflow visibility. But most importantly, Dr. Chuck Webster will help you understand why this all matters for your practice, either as an individual physician, as a group of physicians, in a hospital, or in a healthcare system. Workflow may not sound like an interesting term, but it can certainly change your life and change the way you do your work and actually let you go home happy at the end of the day. We will also hear from a true electronic health record workflow system, or hear how a true EHR workflow system increases productivity and patient satisfaction. This part of the presentation will be done by Dr. George Ragu, who uses a workflow technology developed by Excite Health. We'll also get the chance to hear from Excite Health and their CEO, Barry Hyatt, and learn about the importance of proper workflow management. So let me introduce our speakers for today. So Dr. Chuck Webster has degrees in accountancy, industrial engineering, intelligent systems, and medicine from the University of Chicago. He designed the first undergraduate program in medical informatics, was a software architect in a hospital MIS department, and also the vice president and chief medical information officer for an EHR vendor for over a decade. Dr. Webster helped 3 healthcare organizations win the HIMSS Davis Award and is a judge for the annual Workflow Management Coalition Awards for Excellence in BPM and Workflow, as well as the judge of awards for case management. He became a Google Glass Explorer in June of 2013 as well. Dr. George Ragu regularly sees general pediatric and internationally adopted children in his private medical practice called RBK Pediatrics. Dr. Ragu earned his medical degree from the University of Medicine at Bucharest, Romania, and did his post-grad training at Montefiore Medical Center at the Albert Einstein College of Medicine. Dr. Ragu is also the medical director and founder of the websites adoptiondoctors.com and adoptioneducationclasses.com, where he plays an integral part of the educational component of their services. He has also been an Excite Health user since 2008. Barry Hyatt is the co-founder and CEO of Excite Health. Barry was previously the CEO of Modern Medical Modalities, which owned and managed multiple outpatient radiology centers from 1992. And then from 1992 to 2003, Barry served as a corporate finance and investment banker, helping entrepreneurs as well as companies with various financing needs trying to go public. Barry received his bachelor's degree in business administration and economics from Hebrew University in Jerusalem, Israel. So with no further ado, I'm going to pass it over now to Chuck who's going to start the presentation for today. And just as a reminder to everyone, if you have not attended one of our webinars before, in the middle, on the right-hand side, in the middle of your screen, should be a chat box, and we'd love you to send in questions to the host at 1 Million Solutions in Health, and then I will be the moderator asking those questions as we go along. We'll also put up a survey at the end of the presentation to get your feedback on this presentation and on future webinars. So over to you, Chuck, and take it away.
Let me.
You're now online now. We can hear you. Great. Thank you.
Fantastic. That's fantastic. Okay. Yes. My name is Charles Webster. I am Wareflow on Twitter, W-A-R-E-F-L-O. All of my slides are tweets. People sometimes say I feel like they think I'm tweeting PowerPoint slides, and so that's what I use them for. If you are on Twitter, please use EHR Workflow NOV5. All righty, overview. I'm going to talk a little bit about Ebola, EHR, and workflow as in a kind of a torn from the headline sort of way. And then I'm going to talk about the basics. What is workflow? What is workflow technology? And then a little bit more at length about engines, editors, and visibility. By the way, that's my main blog there, chuckwebster.com. And thank you for everybody who retweeted this outline over the last couple of weeks. Okay, sometimes people call me the workflow bear, and they talk about poking the workflow bear. So they're in some conference, and some guy or gal starts talking about workflow and EHRs and health IT, so they'll take a picture of the slide, they'll quote them, and they'll include my URL or my handle, and you know, I always respond. So it's kind of like I'm a sleeping bear, and you poke me, and I wake up, and I say something. On October 3rd, I woke up, and I had hundreds of mentions and people emailing me, including health IT journalists contacting me through contact forms on one of my blogs, asking me about this headline, which is Dallas Hospital Blames Flaw in Workflow for Release of Ebola Patients. And so actually I ended up quoted in quite a few health IT publications. It was kind of an exciting moment for me to see workflow kind of up there in lights. Now, interestingly enough, the next day, the hospital retracted this statement that there was a flaw in the EHR workflow, and the other half of the health IT community went, aha, it was a human or user error. And we'll talk about that at the end of this presentation. But on the second, when the PR release came out, which I read on the 3rd, it talked about visibility of workflow. So the nurse collected the information, supposedly, about travel from Africa, and this somehow, the result of this wasn't part of the physician workflow, it wasn't visible. And so all of this is going to be kind of a build-up to what does it mean technologically, but I'm going to use a lot of analogy and metaphor to make workflow tasks more visible. Okay, let's start with the basics. I have looked at literally hundreds of definitions of workflow, some of which would fill multiple PowerPoint slides. This is my favorite definition because I made it up. A series of steps, consuming resources, achieving a goal. So if you've ever written out a workflow on a napkin, labeled boxes with little arrows to explain workflow to someone else, I'm sure you're familiar with that. Consuming resources. Each workflow step requires a widget from inventory or the time of some user or some access to some other system it's talking to, and it consumes these resources. It can't proceed without those resources, but it also costs something. So the amount of time the user spends interacting with, let's say, a data entry screen is part of that. And then finally, the workflow achieves a goal. That goal is the benefit of the workflow. So what we've connected up here is the series of steps to cost and benefit. If the costs and the benefit change, if the economics of the workflow change, you should be able to change the workflow. Unfortunately, many workflows in health IT and many EHRs are relatively frozen, and that's one of the sterling qualities that workflow technology brings to EHRs and health IT, is it makes it easy to change the workflow when contexts change in order to make the users happier and more effective, efficient. Okay. A competent ER nurse, OR nurse, hands the right instrument, forceps scalpel, in the right orientation to the right person at the right time. An EHR workflow system hands the right screen, which could have data or order entry options, to the right person at the right time. Now, how does it do that? EHR workflow systems have what's called a workflow engine. So this is a Corvette engine, and it's executing a workflow. Now, if you think about the bad old days, with some of which are still around, 15, 20 years ago, you had to navigate through an incredible thicket of menu hierarchy in order to move from screen to screen. Now, you have to do a lot of clicking to move from tab to tab. And a lot of physicians complain about not wanting to be data entry clerks. I don't think the issue is so much data entry or order entry, it's all the navigation to find what you need. So I heard the other day this guy said he had to look at 10 different places in the system to find the information to write a note. So here we have a very basic workflow. Let's say the patient's being taken to the exam room, and nurse asks about allergies, medications, takes some vitals information, an initial chief complaint, reason for visit, and then another person or role takes over. The physician conducts a physical exam, makes an assessment, prescribes something, okays some codes to go off to the billing system. That's a very, very basic ambulatory workflow. And instead of the user having to drive the screens from screen to screen and find the right screen or find the right person or figure out that they are the right person, the workflow engine is putting up the right screen at the right moment for the right person. And that is part of the magic or the intelligence of the workflow. Now, how does the workflow engine know which screen to present to which person? Well, the workflow engine consumes a definition of workflow. This down here, definition is a short description of a thing by its properties. That's actually a 400-year-old definition of definition from the first dictionary. And so over here on the right, we have the human editor. The human editor can change the order of those steps, change a little bit of the business logic. This is no longer optional. This is now mandatory. Within 5 minutes or 10 minutes, if it's not done, I want it to escalate. All of that can be specified by someone who is not a Java programmer, not a C# programmer, not a MUMPS programmer. Now, we're not here yet, but this is where we're headed. Okay, imagine most tasks are associated with screens. Now, there are screenless tasks. Those are the little dotted lines. But some of these screens are going to have data, such as the last physical exam or the most recent lab values. Some of these screens are going to be order entry screens, such as entering an assessment or a prescription. Imagine you could drag and drop them into your workflow model that's going to be executed by the workflow engine. And then do you double click on them and say, no, this one I don't want to be optional, I want it to be mandatory. And if it's not done, the patient literally cannot be checked out of the office if it is not accomplished, and it will escalate to a supervisor. But this is a more typical workflow editor. It looks a little bit like Viz.io if you've ever drawn flowcharts. We've got these yellow decision points. We've got icons representing nurses and physicians, and this is part of a workflow in an emergency department. And there's something that the programmers and the workflow analysts call the happy path. The happy path is from the left to the right, from step 1 to step 9, and it's what you expect to happen, you normally happen, and you try to facilitate and save people a lot of work and a lot of clicking. And then you have these exceptions down here, so they're dropping down, so it doesn't meet the clinical requirements for that step in the workflow, or the person doesn't have the insurance, and that tweaks the workflow. These can get pretty complicated. I like the pick list model of workflow. It's easier for folks that aren't analysts to see what's going on and to change it, such as delete a step or change the order or change who's responsible for a step. Okay, now we're going to talk about visibility. But before we talk about the relationship between customizable workflow, workflow engines, and task visibility, we need to lay a little bit of groundwork. Now, 15 years ago at HIMSS in Atlanta, so HIMSS 00, this was one of my presentations, and it was called Workflow-Enabled CPRs. This is even before people called systems electronic health records or electronic medical records. These were computerized patient records. In the middle, you have that engine that I'm talking about, the engine that consumes instructions. Over on the right, you have the aviation cockpit. I spent a year in aviation human factors at the University of Illinois during my graduate degree in industrial engineering, one of the top programs in the world, and I learned about Pitt's law and Hicks' law. Pitt's law is the larger a target is, the larger a button it is, the easier it is to hit accurately and quickly. Hicks' law is the number of options on the screen. The fewer there are, the more likely you can select the right one. It's the job of the workflow engine, consulting the workflow model, to put the right buttons on the right screens, and to filter out all of that extraneous, irrelevant content. If you don't have that workflow engine, you get an explosion of the space you have to search in order to figure out what to do next. But even if you have a workflow engine and you have a user customizable and improvable workflow model that's being executed, sometimes tasks still fall between the cracks. And so over on the left is the control tower of an airport. In that tower, you have what the usability engineer calls a radar view. You can see all of the patients and all of the planes, how long they've been waiting in their exam rooms, on their runways, or stacked up. You know how many minutes of fuel they have left, and you can note exceptional circumstances and jump in there and fix them so to maximize throughput while preserving safety. That's actually called BAM, or Business Activity Monitoring, in the business process management world, which I will talk about briefly at the end. Okay, the two major conceptual valuable things that workflow technology brings to electronic health records are smart sequences and simultaneous actions. So sequences could be a task that's passed from role to role or from person to person. And here on the left, we have the patient going from the waiting room into the exam room, the nurse doing some stuff. I've kind of suppressed that detail because I want to focus on the set of tasks that the physician does. Now, a lot of what the physician does is document and then do some orders, and eventually someone will, act on those. But in this case, not only is the physician documenting, but also directing and delegating in the midst, inside the exam room, and the next step. So, for example, this person is late for vaccination. The engine says, okay, well, if that's true, then the next step is to set up the immunization tray. And all of this, the immunization trays, tests, procedures, can be happening in parallel at the same time the patient is in the room. This dramatically reduces the cycle time, which is the amount of time it takes to get into and out of a practice, and can result in a great increase in both patient volume and patient satisfaction, because they don't have to spend as much time in the system. Now, here's an example of an office view, in this case called or a radar view, in this case called an office view. And like I said, most of these are tweets. So I'm having a conversation here with an internist in Montana and a pediatrician in Georgia, and we're talking about this office view. We see exam 1, room 1, 2, and then we see colors here. So we have a green doctor and a blue doctor. So Elizabeth Perkins has the green doctor is their primary care physician. Then there's the blue over here, Sophia Packard. Now, what's interesting about this screen is, first of all, you have a little bit of information about them, but you see the number 8. That's the number of minutes that the person has been waiting. And then next to it, we have vital signs, and then going down the column, we have the exam, vaccine signature, and we see the number of minutes. If we were actually watching the system live, we would see that every minute those would increase. Now, here's the thing. There are a lot of systems out there in which humans update this data so that everybody can see what's going on. This data is live, and it's there because the workflow engine has access to it. It's there as a byproduct of the execution of the workflow engine. So all of this task status information can be compressed together in a real-time report, and everybody can see moment to moment what's going on. And they know that each other knows what's going on. There's just a tremendous kind of mind meld that can happen there. By the way, I talked about task status. Listen to this list. A task can be not in the workflow. It can be in the workflow but not available because it's blocked by another task. It could be started, it could be available, but not yet started. It could be started, but not yet completed. And before it's completed, it might be postponed, it might be canceled. Someone might have to give a reason why. If it languishes too long, it might escalate, okay? And finally, it could be completed. So all of this task information is automatically available, and you can choose the best information in real time And also, it's incredibly valuable for workflow analytics afterwards to spot the bottlenecks and find the rework and so forth. Okay, what's it like to actually use an EHR workflow system? Well, in 2003, 4, and 5, the first 3 HIMSS-Davies Awards for excellence in ambulatory EHR use went to an EHR workflow system. And I'm quoting from those 15-page applications. And in the lower right, you can see EHR.biz, HIMSS-Davies 2003. You can actually pull up the original application, and I'm quoting from it. So, Dr. Cooper, pediatrician, is talking about, he's not talking about an electronic health record, he's talking about a workflow management system. It allows him to customize and streamline collaboration among providers and staff in ways that improve efficiency. For example, while he's in the exam room with the patient, in addition to documenting, he's also directing and delegating. That's that starburst of arrows in the workflow model that are going from the left side with smart sequences out to simultaneous actions. He says, we pass each other, me on the way out, they on the way in. I go immediately to the next patient while they immediately perform their procedures. I don't have to find them, I don't have to tell them what to do. I visited a practice using an EHR workflow system, and it was really strange. It was like one of those Stooges hallways where the 3 Stooges, and they're running out of the doors and they're crossing into the other door, and they're not without saying anything to each other. And what I couldn't figure out is how do they know where to go next? Well, as he says right here, it's the EHR workflow management system that's taking care of that task-driven communication, which is what workflow systems and EHR workflow systems excel at. Let's look at another one. This is in 2005, Dr. Harris, Family Medicine, Obstetrics and Gynecology, and he talks about we've got one screen at a time with only the most relevant data displayed and options presented. That's the aviation cockpit, where we're using the workflow engine, the knowledge of the workflows of the pilot and the co-pilot and the navigator to strip out all of that extraneous stuff and only present the relevant information. He goes on to say, well, a user can always jump out of a particular screen sequence to accomplish a task. So you're not a slave. It's really just being helpful. And if you keep jumping out of that workflow, maybe you need to go back to that workflow model and tweak it. So he says sequences can be tweaked through the workflow management. That is going through the workflow editor and changing the description of workflow, the model of workflow that is driving the workflow behavior of the system. The workflow plans can be tailored for each type of patient. So, for example, a well child visit that is an annual physical versus a child coming in for management of a chronic asthmatic condition. A different set of screens queued up to different folks, different business logic, and all of that can be customized by the practice without having to go through a Java or a C# or a MUMPS programmer who really doesn't understand their workflow. And then down here we have the work plans, which are the workflow definitions, contain the required tests for specific conditions, so they're not forgotten. They're not forgotten because when they are queued up, they don't go away. You see them in the office view, and they hang around. The patient can't leave until they are either accomplished or dismissed for good reason. Okay. Now we've come to the conceptual core of what I'm talking about. And I like to talk about the power of process, the power of executable process models. So in the middle here, we have models of work, models of workflow that are executable, that are mechanically consultable in order to help the users. And in the middle, we have this Vis-IO model version, and here we have the pick list kind of version, which is, patient go to the exam room, ask about meds, ask about allergies, collect some vital information, and then it moves on to the physician and on to billing. Well, you may have seen this little colorful gadget right here. This is a workflow. The red corresponds to clinical assistance. And we're, vitals, meds, allergies. And down here, blue corresponds to the physician, exam, assessment, and treatment. Green here makes sense, is the billing. And the happy path are these black arrows, and the exceptions are the red arrows. And now this model is probably only a third or a fourth as many of actual workflow task states in a sophisticated ambulatory, but I think it illustrates. But this model is something that's in between the computer and the workflow engine but it can be understood and executed. And over here, we have someone who isn't a programmer who can understand that workflow and change it. And this is the layer that's missing in most traditional electronic health record documentation systems today. They are documentation systems. They are not workflow systems. Here's a hospital context, and this is a slide I tweeted. We have Ottawa Hospital. They're working with IBM, and up here we have a patient. And then they go home, but in between we have all of the workflows and the tasks and the information that's flowing, labs, nursing unit. Down here we have all those terrible databases full of images and structured data. And this layer right here is missing in most health IT environments. So the users have to navigate and figure out what table and what row and what column to find the information, and maybe 10 times like the guy I mentioned earlier just to write a note. Instead, we need to have a model of work that is executable and is improvable. So right here we have the beginning of the workflow. Over here we have the end. We have diamonds corresponding to various kinds of logic. Here's a timer. That timer could represent wake up at 3 a.m. in the morning, download some information, look at the meta information, put a tickler in the right to-do list. We have data right here that's being transmitted to and from the system. I talk about the importance of workflow interoperability. We need this layer of workflow, this model of work, to really make the syntactic and semantic interoperability that most people focus on valuable. Okay, we're going to zoom back out here. I've been using the term workflow and workflow technology because I think workflow is a popular term, I think, in healthcare. But the workflow management industry has really now called the business process management industry. And healthcare doesn't really always like the word business. So you'll often see clinical process management or healthcare process management or care process management. But if you drill down and you look at the footnotes, you'll see what they're doing is they're leveraging business process management suites, workflow engines, orchestration engines. In fact, a number of the more sophisticated population management systems and care coordination systems that are coming out onto the stage right now in health IT are in fact based on business process management suites of various brands. Okay, back to Ebola, EHR, and workflow. Now, let's say we've got the workflow model there and the travel information is optional. So we go in there and we click that. We say, no, we're going to require it. It's going to become required. And by the way, if it's not accomplished, we can't check the patient out. Workflow models are declarative. They can be transmitted. You can export them as XML and you can send them. So you can imagine workflow models being transmitted from public health departments down to point of care EHRs in ambulatory and hospital environments. The nurse collects this information, and somehow it didn't get to the physician, at least in the first version of this. Well, EHR workflow systems excel at task-based communication. They do very, very well exactly what traditional EHR documentation systems do badly. And so the nurse, it would have been very, on the fourth, remember that group of folks who said, you know, just because you have an EHR doesn't absolve the clinical care team of the common sense responsibility of communicating. The nurse should have taken the physician aside and said, look, this guy just got back from Africa. Well, guess what? In a workflow system, it would be very easy for the nurse to simply click recheck and assign the duplicate task to the physician role. And that physician would not have been able to leave the emergency department until the physician saw it and signed off on it. Okay. Of those three HIMSS winners, this is my favorite. Dr. Gonzalez is in Chicago. He's spoken at HIMSS. And he's got this quote. You can actually go to the URL here, ehr.biz, HIMSS Davies 2004. And he says, it's really helped my lifestyle. I'm working 3.5 days a week. I used to work 7 days a week. So now it's really made life much easier and the staff love it. So it's really made life much easier and the staff love it. How often do you see that being said about traditional EHR documentation systems? And look, he used to work 3.5 days. He used to work 7 days, now just 3.5. He has doubled his productivity. This system has made him able to accomplish twice as much with the same amount of work, or as much work with half as much effort. Whereas traditional EHR documentation systems do the opposite. They often double the amount of work and make people stay late. Okay. I am so delighted to be here in this digital bully pulpit. Workflow technology, BPM, adaptive case management is diffusing into healthcare across a multiple fronts, social, mobile, analytics, cloud, and I'm happy to try to help accelerate that. I'm Wareflow on Twitter, W-A-R-E-F-L-O. I have about 1 million words about healthcare and healthcare technology out there. Just search for Chuck Webster Workflow, you'll find it. There are contact forms. I hope you will join with me and become a workflowista. Viva la workflow. Thank you very much.
Thanks so much, Chuck. We really appreciate your presentation today, and we're going to pass it over now to Dr. George Ragu, who will talk to you about his real-life experiences. So over to you, Dr. Ragu. You just have to unmute yourself, and you're away to the races. Thanks.
Hi, how are you? I'm Dr. George Ragu. Can you hear me? Am I connected?
Yep, you're perfectly fine. Thanks.
I'm a pediatrician with a practice on Long Island, New York. We've been using the Excite Health software since 2008. We have about 12 or 13 providers, doctors and nurse practitioners with 3 locations and an urgent care facility. Dr. Webster did a great job in presenting the ABCs of pediatric workflow technology. Now I'm going to actually show you and demonstrate how such an EHR could help with great workflow and make the practice more efficient. I first got involved with EHRs in the middle of the years 2000 because I was very satisfied with how medicine was and how our office was practicing. People were unhappy. The wait times were great. People kept coming because they loved the doctors. And then one day, I went to lunch at this really good coffee shop, sandwich shop. It was terribly inefficient. 1 million people, just like our office. You waited on the line, placed your order on a very big line, walked all the way to the other side to the cash register, and paid your bill. Now, I made a mistake, and they gave me something that I didn't want, so that person had to go all the way back and get what I wanted, and then I had to pay. Just made the whole process inefficient. I was frustrated, and I compared that to our medical practice. Then I went to another place called Panera Bread. Just as many people, just as good food, ordered, somebody touched the screen, I went down, and I got my sandwich in 2 minutes. And I said, wouldn't it be great if an EHR could do that? And then I stumbled onto Excite Health. And then I thought it was great with their touch screen capabilities, and then I just searched other EHRs before I came online with them in 2008, and I could never find one that was as good as they were. And then when it was time, they were the one to choose. Now, I'm going to show you a little bit of what he was talking about with the office view. You can see the office view. I can see what's happening at all moments in time. There are 3 rooms happening right now. Each color on the left side is the color of a doctor. I am the green doctor. The pink is usually a nursing duty, so the nurses know what to do. We have different types of patient templates. You can look inside the virtual waiting room, and you can see that there are 6 people waiting to be seen for 1,593 minutes for different types of visits, ADHD visits, sick visits, weight intake visits, pre-op clearances, asthma, and all these have their own service bars with their own pre-populated procedures that need to go with them, as well as different types of flu shots and vaccine visits. So this software is like the quarterback of our business. It helps to direct our team to the right patient at the right time. Our software has proven itself to increase productivity, increase patient satisfaction, decrease wait time, and believe it or not, increase revenue. We do not see patients that stay in the office very long, and we do not take charts after hours. So I'm going to show you how to use the global view. The global view is what's happening in the office. Right now we have the front desk staff. She has a referral to make and a follow-up. The nurses have a hearing and a vision screen to do for the doctor before he gets into the room. I am going to demonstrate a regular routine sick visit at this point. So I'm going to take patient Theodore Rogu, who is my son, so I can allow you to see it. We set up for meaningful use a a mandatory screen where the nurses have to view when the last blood pressure was done, and if it wasn't done within the quarter, they have to do a blood pressure, and they can see the last heights and the weights. Usually this becomes the nursing job before I ever come to it, and they put in the chief complaint. They're here for diagnosis of asthma. Everybody pre-populates this content with whatever they desire. They can put in some vital signs very easily. It's much easier with the touch screen. And temperature, and the system will alert you when there's something that's abnormal with a red flag. Some offices have the medical assistants add the outstanding medications, the current medications and current allergies, which can be added very easily from here, but the doctors have their own service bar in my office, and we do it ourselves. So the nurses just check in the patient. So now in the doctor view, I can see that this patient has been waiting in room number 1 for me. I take over the chart. I get a quick view summary of what's happening in the office, very important for meaningful use. It gives us an idea of the patient had some outstanding referrals to the ear, nose, and throat, where the patient, if you see that it's outstanding for a very long time, you can always ask that whatever happened with this, and you can document some follow-up notes on it. You get an idea of the medication list, open diagnoses that the patient may have, health maintenance rules that the patients will need. These are all pre-configured by the individual doctors, and the vaccine histories. Now, this is where the action happens. The doctor picks in the patient. We have pre-made templates. So let's say that this child is a sick asthmatic, all right? So I have my jargon that I use here routinely written by me, and I know he's an asthmatic. So he has a history of asthma and wheezing, ill for a prolonged period of time, seems to be getting worse, congested cough, worse at night, been using inhalation therapy, little relief. Let's say I want to add also has a sore throat. Now, if I want to use this for the future, I just add it to my list, and it goes to the bottom, and I can use it the next time around. See how it says also has a sore throat. So doctors like to write in their own lingo, so everybody can do their individual stuff. And we have the review of systems. Generally, you can select all and then entertain what is important. So Johnny had a sore throat, runny nose, and a cough, congestion, and some trouble breathing. You can expand on chest is cold. All this can be configured individually. You can review the past medical and social history. Usually all the data is documented over here. To review it, you just review no changes, and it stamps it in the progress note. Or if you want to change something, you can add that very simply by clicking it. Has a history of asthma. Use the nebulizer in a month. Winter months triggers the seasonal changes, allergies, and common colds, and that'll stay in the child's past medical history. You just adjusted it very easily on the fly. And that stays on for the future. Medication list, you can see what the patient has. If you want to, and you just say medications reviewed. Allergies, if the patient has an allergy to penicillin, it tells you there. If you discover that he's allergic to tetracycline, you can easily just add it on the fly. Like I mentioned, the nurses can put it on their view, or the doctors can put it on their view. It depends. The next sequence is the open diagnosis. You can look to see what the patient had been coming in for. You can also look in the past to see what are past diagnoses that this patient has. So with all those children that come in with wheezing, reactive airway disease, and so forth, if you see a lot of that, you can ultimately make your diagnosis of asthma. We put in a mandatory smoking status bar, which is required for meaningful use certification. you cannot go past this without entertaining it. They either smoke or they don't smoke, and you have to stamp it. The chart does not progress, as Dr. Webster told us about earlier. Now we have our general physical exam. Our general physical exam, the standard normal for a sick physical exam, was created by all the doctors in my organization, and we decided that this was what we wanted to do for a standard quick physical exam for a sick visit. If you want to change something, like if you want to put in wheezing, you have to remove everything and just add rales, rhonchi, wheezing, and that gets put into the physical exam. So this way, that came about because there have been EHRs that, you know, had testes bilaterally descended and the kid was missing the testes, and how do you explain that in the court of law? So we remove everything and then we put in the positives. The best thing that I like about the EHR is your assessment and diagnoses. You can pick from, you pick your diagnoses from the sick diagnosis button. But before I do that, let me explain a little bit about the chart view. The chart view is an overall screen where everything happens. You can access any piece of the EHR. If you want to order a laboratory test, you can just quickly order a strat test. If you want to show the patient the growth chart of the child, you just hit the growth chart, and with all the pre-populated data from the nurse's vital signs, it gets put into there, and the BMI gets calculated nicely. It also gives you the actual data, the percentiles and the actual numbers. Now back to what Dr. Webster was alluding to with the vaccines. The system has logic with what vaccines are needed. Now, while most people know what vaccines to give to the child, the system does help you to tell you that this patient needs the second HPV, and you can see the rules right here. I have, just because I'm of the generation where we had to count what vaccines were given, I always look, and let me tell you, I've never found the computer to be wrong. It could almost replace me. And so that's the office view. And I have to give you a diagnosis. Oh, I want to order first a vaccine to show you how easily we can order a vaccine. The vaccines get ordered in the Well templates. We have different service bars that pop up, so it's a little bit easier. There's no bouncing around. But let's say I want to order a Gardasil vaccine. So now I ordered the Gardasil, and I also put they need a third follow-up in 4 months. So now I'm sending an appointment to the front desk at the same time. We have the vaccine held into the VFC eligibility because sometimes we found when we went live with the system that a lot of the doctors were cheating, and they were ordering the vaccines just so they knew that the nurses would pick it up, and so they wouldn't get delayed. But what they were doing was something would happen, they would end up speaking to the patient, and the nurses were sitting outside the door waiting for the doctor to open the door. So what we did is we put this little holding thing, so it's basically the Vaccine for Children eligibility request. So you can put, you know, they have Medicaid and they don't have health insurance, and this actually satisfies any of the New York State Vaccine for Children problems. Now I'm going to show you a little bit of what the nurses do with the vaccines. So now the nurses look, they can look at the office view, they can see what's going on. In room exam B, there's an HPV vaccine that needs to be given. So they quickly take it over, they click, they put in the lot numbers and everything, and they say immunization, oops, I don't know how to do this, lot numbers. And this is a nursing job that I don't know how to do, obviously. And they give the shot, and then they get a signature, usually on the screen. as if they gave the shot. So now we had ordered a follow-up Gardasil in 4 months, and we also ordered we forgot that we ordered a strep test before. We put that in the queue also because the doctor would do the strep test. Now it went for the nurses and they can provide the service. So in a quick nutshell, that was a progress note, relatively quick. Now, we also found with well checkups, you know, everybody knew what you needed to do for different ages of well checkups, but sometimes the newer staff, the newer nurses would forget that they'd have to do a hearing and a vision. So in order to increase that efficiency, what we did is with different types of visits, we have already pre-ordered hearing and vision tests that the nurses have to entertain before the doctor actually sees the patient. I'm not ready for him until these are completed. So the nurse has to do the vision screen. They have to finish it off. And then, oops, I locked this out. I'm not very good at the nursing part. And then only until the nurses finish their job does the doctor get the complete results over here. So so they come in, and at the checkup, you can tell that he had a hearing test. You can tell the patient that he passed it, and the vision test, he passed it. Again, I remind you, this goes much faster when it's done on touchscreen. Now, the beauty of this thing is now all our super bills and everything went away because as you're doing something, you get your diagnoses for the patient, you get the kid a flu shot, and it starts to get stockpiled, and then we have they go to a billing room that one of my staff members, they go every single day, and they just manually, quickly they look over the chart to make sure that everything's okay and linked properly, and then they send it over to the practice management system. So I think that's all I have to say. Hello?
Great, great. Well, thank you very much, Dr. Ragu. We're going to turn it over now to Barry Hyatt, and he's going to take us through his presentation next. We're going to tab over one more, and I think we get your presentation, Barry, at the very top.
Okay. Can you hear me? Can you hear me? Hello?
Yes.
Yeah, you can hear me. Okay. All right. First of all, thank you, Dr. Ragu, for the great presentation, and Dr. Webster for the educating us about the workflow. Also, I'd like to welcome everybody, all the participants, and thank you for joining us this afternoon. I got into the healthcare industry in the end of 2001 by taking over a near bankrupt company who owned outpatient radiology centers. We had radiology centers in 5 different states, and the very first thing that I noticed when I got in there is, we're talking like in the end of 2001, is that we had so many different systems or software that we had to install in order to, hold on, let me just make a big screen out of it. Okay, and so many systems that we had to install, and every time we had to install a new system, we had to buy a new computers, and we had to build interfaces, and it was just a mess. We had over 100 employees, and it was just not working. So around 2005, 6, I came across a startup that started to build a cloud-based solution that was addressed to the industry that's supposed to take care of the managing the people, the HR, the medical record, the practice management, the billing, and inventory management, and so forth. And at the time, I was amazed with this opportunity to be on the cloud. They were really pioneers. People didn't understand what cloud is. But being a provider, I understood it intuitively because I realized that I spent probably at that point close to $1 million on hardware and software and servers in order to get efficiencies, and those efficiencies were not really realized. And the biggest thing that we realized is workflow. So I invested with these companies, and we went out and we built this software, and we brought it to the market. So within 9 years, we basically sold the clinics for about 20x. We did very well on it. We exited from that, and we went to the marketplace to implement it. And as we started going to the market, I came across the Encounter Pro software, this EMR, EHR that you just saw. And even though we just built our own, when I saw how fine of a job they did on the workflow, and we realized that we're going to adapt it as our main EMR, EHR, and use the rest of the cloud-based system that we built, whether it's practice management, the patient portal, provider portal, HR, inventory, vaccine management, and so forth, and it goes on. And I was really, really impressed coming from the provider world with its ability. What this software is, you can think of it as a quarterback in the office. Quarterback to you, the doctor that gives you the right screen, like you saw, the right screen at the right time, that's on the action you took. Saying at the same time simultaneously the right task to the either, whether it's the nurse, the front desk, whatever it is. You don't have to call them, they don't have to see, they're looking at the office view. Each role player has his own service bar, there's a timer on it. And now everybody is synchronized, everybody's working in concert. And it can be monitored so many times again. So based on that, we decided to take that product. And over the last 3.5 years, as you can see on this list, we have been enhancing it over and over. And obviously, with all the regulation that's going on, as you can see, we had to go through a couple of certifications. We just finished the MU2 complete certification. We have a practice management that is fully integrated into this with patient portal. And we pretty much replaced and changed everything. And most important than all is obviously the support. Again, we want to the stress is the interoperability. As you can see, we have a ton of already practice management interfaces that we have. We're in the process of adding another 5. This is for customers that, they still want to maintain and keep their own practice management, so that's not an hindrance, but they want to take advantage of this workflow engine. And the same thing goes towards labs interfaces. As you can see, it's operable. Before the year is out, we're going to have immunization with over 20 states, and next year we're going to add another 20 states. As you can see as well, we already got the interoperability with the patient portal and the marketplace that we're putting in place as well to help doctors also get new patients as well. So not only that we want to help them run their practice, but next year we're going to also help them manage the patients easier and help them to try to capture easier new patients and communicate with them. I would, before we run out of time, I'm going to turn it back to Dawn for questions. Please feel free to ask questions to any one of the speakers. Any questions? Okay, now I'll turn it to Dawn, and if you have any questions, please feel free to ask any one of the speakers.
I can hear you.
Dawn? Hello? Dawn? Hello?
Okay, we'll try again. Can you hear me now?
Now I hear you.
Okay, great. Sorry, I was asking questions, but I guess no one could hear me. My apologies. So maybe my internet connection was a little bit slow. So yes, I'm going to encourage anyone to stick more questions into the chat box, but we'll jump in here for the first question for Dr. Chuck Webster. What obstacles are there to getting better workflow technology adoption, and what needs to happen to increase adoption?
That is a very, very good question. And my answer is three things. I'll try to keep this short, and that is, first of all, education. There are a lot of precocious physicians who are becoming CIOs, and they're learning just in time, and they're learning about workflow technology from other industries, which are literally decades ahead of healthcare. Number two is we need to find the health IT people and the EHRs that are already doing workflow well. They may have developed their own proprietary EHR workflow engines and so forth, and to highlight them. And I didn't show it here, but I have something I call the POWHIT badge. It's a social badge. POWHIT stands for People and Organizations Improving Workflow with Health HIT, and POWHIT, like, you know, the Batman TV show. And number three, I think we need to harness the workflow technology industry itself, the BPM industry, which is 1/10 the size of health IT globally, but is growing 3 times as fast. And so I know of folks that are swapping out their proprietary homegrown workflow engine for, workflow engines from third-party vendors. And so that's my answer in terms of changing an industry. I think those three are those are the times of the fork or whatever, to mix a metaphor.
Okay, sounds great. Well, thank you very much. Can you hear me now?
Yes.
Okay,
yeah,
great. Thank you. So, question for Dr. Ragu. How, in your example, would the combination of fever and travel from West Africa in the last 21 days trigger an alert or branch that ensured closer physician scrutiny? Or are there other ways within the system that could be highlighted to someone else in the practice through the workflow?
Well, that would have to be configured a little bit. It's not very complicated. Today you would want to make it a mandatory step. So you would just create a service bar with visit reason for fever. What we did was, in our review of systems where there's a fever, we just added in that context, what is the travel history? It's not mandatory, but if it needed to be mandatory, we could make it mandatory, where we just just make another service bar. Like if you recall, where I had that first service bar where it was meaningful use to check the vital signs, you can make one of those things travel history. The doctor cannot go forward without asking or the nurse.
And I guess someone who was thinking about it could probably send an alert to another practitioner in the office?
Yes, you can. There is a feature in Excite Health where you could send alerts that pop up when anybody touches the chart. We do that a lot with people that they don't like vaccinations or they're behind on vaccines. So today's doctor will say, at the next visit, give the MMR and the varicella. So when the doctor goes in and touches that chart view, which is the big picture view, it automatically pops up and it tells them you should do this.
Okay, great. So here's another question for you. Do you see any gaps between your Excite EHR documentation steps and the final billing to the patient in the PFS business office?
Do I see any gaps? I think, nothing can happen in the system without an order. Without an order, a bill cannot be sent. So we've made it mandatory where a nurse will never take a verbal order from the doctor, even if it's from me, without it being done in a computer. This way, if I order it in the computer, it will go to the billing side, and then it'll push over to the practice management side. We have a different practice management system that's interfaced with Excite Health. I still have a human being look at each bill before it goes over, just in case. We probably one day could get so seamless as to just let it go. But just like with the vaccines, Even though the computer tells me I need to get the HPV vaccine, I still look. I guess old habits.
Okay, sounds great, thanks. So this one maybe is a bit more for Chuck or Barry. How do you manage security concerns of using cloud solutions with HIPAA PHI?
I'm going to turn that over to Barry.
Okay. We have, evidently, we have a 256 encryption on the cloud. Everything is a HIPAA compliant. We have roles and privileges that are monitored, and we actually, not only that we meet the HIPAA requirements, we actually exceed them significantly.
Okay, great, thank you. So here's another question. Have there been concerns with data safety regarding the cloud network? So this builds on it. Are people able to upload data from external monitoring devices or only from clinician interface? So again, Barry, do you want to take that one?
People can upload information. Evidently, again, it's very secure in the sense of roles and privileges, who is allowed to do what, and also the access to what folders they can access. So all that is monitored through it. And we also have a tracking system that we can see exactly who is doing what to where. And this way, the administrators, they can manage all those roles and privileges and actions and access to certain files and databases.
Okay, great. So this one maybe I'll send first to Dr. Ragu and then maybe to Barry. If I already have IT technology, do I need to get rid of what I have to use Excite Health, or can I interface with what I have?
I guess that one would be good for me. My office is a poster child for interfaces. I have a practice management that interfaces with Excite Health. I have an other patient portal that interfaces with both the patient, the Excite Health and the practice management. I have a meaningful use reporting system that takes all the data from the EHR and scrubs it and puts it in nice, pretty spreadsheets. And I use that for the meaningful use with CMS, and I'm sure I'm forgetting something else. But you don't have to dump everything.
Right. So what we did is we're very flexible. It's depending on the customers and the setup that they want. Like Dr. Ragu, he has a lot of interfaces. But Excite Health as the complete solution. We have our own practice management. We have our own interfaces with the various labs, and also with the immunizations, registries. And so if the customer wants it on a hosted, we accommodate that. If they want it to be locally, we accommodate that. If they want to work with certain vendors they're already working, including IT, we accommodate that. We offer all-in-one, but we also work on a case-by-case basis based on the preferences.
Okay, great, thank you. And just for someone who's asked, yes, this webinar is being recorded and we'll send it out to people afterwards. So for Chuck, how do we engage care delivery enterprise organization CIOs to adopt workflow technologies? That's a big question.
And it's an excellent question. Last year, I actually co-facilitated a focus group at Chime in Arizona. We had 40 CIOs of the top medical centers in the United States, and we talked about workflow, business process management. And the interesting thing is, and this is part of another trend, I've noticed job ads looking for hiring CIOs and even CEOs of hospitals in which they say lack of healthcare experience is a plus. And so basically the CIOs in these hospitals who came from other industries that have been using business process management for almost 20 years are ideal candidates for helping that technology diffuse. On the other hand, their plates are so full of ICD-10 and meaningful use that it's a battle. And so we have to make our case as enthusiastically and as credibly as possible in the ways that I referred to earlier. Find and highlight, harness and educate.
Okay, great. Thank you very much. So I'm not really sure who wants to answer this one, but I'll read it out. Why do you think existing EHR systems, both ambulatory and hospital, have not yet, if ever, implemented workflow engines?
I'll answer that.
Okay.
Well, health IT about 20 years ago, maybe 15 years ago, came to kind of a fork in the road. There were early workflow systems implemented in HIT. Health IT, and I don't mean to offend anybody, has a bit of a data fetish. Okay, it's all about the data. Well, guess what? It's also about the workflow. And when you set up very ambitious goals involving data collection, and it sucks all the air out of the room and you can't address the workflow issues, then you have a misbalance. And so what I'd like to see is if we could, take instead of 90% data and 10% workflow, if we could do 70% data and 30% workflow in terms of emphasis and hype and education and money from the government, and investment from venture capitalists, I think we can maybe start to shift the balance back in a more equitable direction.
Okay, great. Thank you. Dr. Ragu, do you ever need to take charts home after hours to complete records because there is no time during the visit?
That has never happened. We complete the visit during the visit. So I go through each step and I turn around and I speak to the patient, and since I'm using my fingers, very little mouse clicking, it's very efficient. I have not one time taken any charts home. But that is a common complaint that a lot of doctors have with other EHRs.
And I guess I kind of just heard you also say, and I have experienced this as a patient, is you actually get to look at me in the face with this perhaps system, where sometimes I find the physicians are buried in their computer and not even looking at me anymore.
Well, I have a hardwired, they're called Weiss devices. It's plugged into, it's on the wall of every exam room, and we have a keyboard and a mouse. That's all that's visible. So I touch the screen, I'll go through something, I'll turn around, I'll touch the screen, I'll write some more, I'll turn around. You have to do that turning around. You cannot sit face-to-face with the patient, but this is the next best thing.
Okay, and then perhaps a related question, do you see less patients than with paper charts?
What has happened is our office is quiet all of a sudden. I think we see more, if not the same, volume. We definitely do a better job of documenting, and I think by doing that, you do a better medical job. We do better recallers and follow-ups. And I think we do just as much as we did before, but there's no more stress, and everybody leaves on time. Everybody's happy, and the patients are happy. We have a law in the office. If it's a sick visit, from check-in to check-out, no, from check-in to the time the doctor leaves the room and is finished, has to be within 30 minutes for a sick visit. And for a well-care visit, it has to be within the hour. That's pretty darn good, I think.
Okay, great, thank you. So again, this one is, I'm not sure who wants to answer it, but do you see wearables and workflow EHRs working together?
I'll take that. I'm actually giving the keynote at the Society for Health Systems Healthcare Systems Process Improvement Conference in February, and I am talking about wearable workflow. And the relationship between Google Glass and notifications sent to smartwatches and to other gadgetry and how they fit into the larger enterprise health IT system. And so I don't want to give that presentation to you now in response to a question, but yes, there's a tremendous opportunity. I'll just give one example. One of the Google Glass companies is estimating they can reduce maybe 30% of the interaction between the physician and the EHR can be offloaded to intelligent alerts that come to the physician, and the physician doesn't have to go off and search through the EHR to find the data.
Okay, great, thank you. I think this one's probably for Barry Hyatt. Does Excite integrate with personal health records like Microsoft Health Vault, and can it send direct emails to patients?
It's not integrated yet with Microsoft, but we can send direct emails to patients. but not directly from our system.
Okay, and don't you have a patient portal component to this?
Yes, we do. We have the patient portal and the practice management and a provider portal as well. The provider portal is a tool for the providers not only obviously to communicate with the patient portal where they can obviously do the secure messaging and they can send the medical records and so forth, but also the provider can use it to do announcements to the patients, to do marketing if he wants to, and a lot of other functionality that we give the providers as well.
Okay, great, thank you. So for Dr. Chuck Webster, how do we include the patient in the workflow?
What a wonderful question. I actually have a couple of blog posts about the relevance of workflow technology to patient experience and engagement. And in fact, it is in the consumer-facing, patient-facing, cloud-based social startups and platforms out there that I am seeing the most sophisticated workflow technology. So folks are developing these using what are called less code or low code techniques, where they're drawing the application, they're drawing the workflow, and these systems are very natural for, let's just include the patient as another member of the team. So you actually model it. You actually, when you create your workflow model, that workflow model, those resources are not just doctors and techs and nurses and admin, they're also the patient. So we're making the patient a first-class citizen in the process-aware information system. So I think that we're just scratching the surface, and as I said, some of the more sophisticated workflow technology is actually coming into health IT from these consumer-facing, patient-facing systems.
Okay, great, thank you. Another question, it's just open to anyone. What is anyone's opinion of YAWL, yet another workflow language? So Y-A-W-L, yet YAWL. I've just started reviewing it.
I'll talk. I'm familiar with YAWL. YAWL is an open source business process management application that you can download for free, developed by some Dutch researchers. They may actually be listening in. It's an excellent educational tool. I don't know that it's actually been pressed into actual everyday use. I know that people have tried it out and prototyped it in hospitals, but it's basically a free open source. And in fact, if you ping me or email me, there's about a dozen open source business process management systems out there, and they're getting better every day. And I'm hearing more activity where people are saying, you know, let's try this out in healthcare.
Okay, great. So a couple questions here for Barry. Can you fully implement and train a new practice this year in time for MU2 attestation?
Yes, time is running out, but if it's a matter, if we engage in the next, I would say 2 to 3 weeks, then we will be able to do so.
Okay, so a related question is, how long will it take a practice to implement the Excite system and get productive?
Well, we live by live in 5. We basically, if you do, it's up to 3 physicians per trainer. In 1 week, in 5 business days, we can get you live up and running.
Okay, great. And just again, while we're on you, so I've not seen anything like the Office View before, but also wanted to know, do you also offer a billing service?
We will be offering a billing service sometimes probably in the 2nd quarter, maybe late 1st quarter or 2nd quarter of next year. A model where the physicians will be able to use our entire software and only pay for the billing service.
Okay, great. So for Dr. Ragu, how is this different from other systems you have used?
It is different because I've reviewed lots of systems, and they are all basically just glorified progress notes. This is more than just a progress note. It's it just makes the office run efficiently. Like I said, from orders to billing to movement of patients within the office, and then also the progress notes. I mean, I think EHRs and progress notes was news from 5 years ago. I think this is the future.
Okay, and maybe you can answer this question as well too. What other systems does the Excite EHR communicate with?
Barry should answer that.
Okay, I thought you had.
You mean
what I have? I can tell you what I have.
Yeah, that's what I meant. You tell us what you have, and then Barry can tell us it more globally.
Okay, I have my practice management system, which is called PCC, Physicians Computer Company. They do the practice management and the scheduling and the billing. I have Excite Health for the EHR. I have a patient portal called Concierge MD, where the patients can go back and forth, make their live appointments, and get all the medical records from Excite Health and the vaccines. And we have Clinigens, which does all of the meaningful use data scrubbing and collections. So those are systems, and we have the nicest registry and labs interface with Quest and LabCorp. Okay,
great, thanks. So Barry, do you want to add on to that?
Like I showed in the slides earlier, we have over 30 practice management interfaces already, all the major ones for sure. We also have over 30 lab interfaces, and we in the process of implementing over close to 20 on the first pass state registries for immunizations. We also in the process of building for the portal we talked about an interface that we pretty much will be able to talk to all the major practice management systems, even only for appointment and history and so forth. And evidently we're ready to interface with whichever system the customer would like.
Okay, super. So here's a general one. Actually, I've got 2 more questions, so if anyone has any more questions to put in, please put them in now so I can finish them up. That would be great. So for anyone, I thought workflow was about interoperability, but I didn't hear it discussed.
I'll take that. There are 3 kinds of interoperability. The terms all come from linguistics. There's syntactic interoperability, which basically means can you get the data from one system to another. There's semantic interoperability, which is, does the data mean the same thing? So you've got some number or code, does it point or refer to the same drug or diagnosis? But out in computer science and theory land, there's a third kind, it's called pragmatic or workflow interoperability. And it's basically when you send a message from one system to another, does it have the effect that you want? Does it achieve the goal you want to achieve? And the current systems that are focusing on interoperability at the syntactic and semantic level, when there's a problem and they send over some information and it's kind of garbled, you can use the workflow interoperability level to say, hey, I just got a garbled message. Is it what you really intended to send me? Could you send it to me again? I'm going to escalate it on my side. Could you escalate it on your side? And so that kind of conversation between systems is really missing from systems that are workflow oblivious. And we need to add workflow. So really, even though I was talking about workflow, I did mention, a task to wake up at 3 a.m. in the morning, download some information, and read the metadata, and then put a tickler in the right to-do list. That's interoperability too.
Okay, great, thank you. And Barry, perhaps this last question is for you, and then we'll let you each give like a quick closing remarks. So these models of workflow that drive electronic health record, EHR workflow behavior, where do they come from? Do I have to create them?
When the system comes out of the box, we have a lot of content that already built into it with almost close to 17, 18 years of experience and working in so many different practices with hundreds and hundreds of doctors. So we created, for lack of a better word, some kind of a standard read content already. So that's ready to go, but the doctors, any doctor, like Dr. Ragu said, they can configure and change anything along the way, and each doctor can go with his own treatment plan and that suits him and suits the way that he wants to practice medicine. He doesn't have to follow a certain progress, notes way or that is already built into the system. He doesn't have to look for the right fields to fill them in. Here, like Dr. Raghu has demonstrated, once he configured any changes that he wanted to do, when he presses a certain button, he gets a screen that is a result of the action that he made. And like I said, it's pretty much ready to go, but it can suit anybody's configuration.
Okay, great, thanks. So since you're up, actually I've got one more question and then we'll let you guys do a summary, and I'll start with you, Barry, on the summary side. But one more question is, healthcare workflow is more than clinical workflow. Does Excite tackle the business of healthcare workflow?
Actually, Excite, like I said earlier, I started investing in 2005 and 6 in a cloud-based system. At the time when we were saying cloud, people went to basically to Wikipedia, find what is cloud computing. We didn't call it cloud, we called it Internet 2.0. So we built a system that we thought at the time not only that we're solving it being on a cloud, but we tackled actually the entire healthcare industry. So the Excite system is not only an EMR or an EHR and practice management and patient portal. We also have the entire business functionality that help manage the people, the inventories, the purchasing, the CRM, accounting, believe it or not, but we also built it for the payers. So we have like contract management, we have credentialing, and we have even health plans. So we build a system for payers as well, where they can take the system and literally write health plans, manage the doctor networks, manage the medical, and so forth. So when we came across the Encounter Pro and we saw how superior the workflow is for the clinical side, we decided to adapt it. We've been putting a lot of effort into enhancing it and incorporating it into our cloud-based system. And over time, we will be rolling more and more healthcare and business functionality to complement the practice management related things, the clinical and the patient portal communication.
Great, thank you. So I'm going to let you do a closing remarks, then we'll move over to Dr. George Raghu and then Dr. Chuck Webster. So over to you first, Barry.
Like I said, the reason I got into that system and decided to actually take it over our system is because I was amazed at two things. One is obviously the workflow, but the workflow became a word so commoditized that almost it doesn't come across. And as you can see, this system is the quarterback of the office. You have the office view, and like Dr. Raghu said, it's so quiet because nobody needs to flag anything, nobody needs to scream anything, nobody needs to yell anything. And it's very efficient as the user basically using it, the system already based on configuration, the system already know what screen next to show to the user, what message to send to his counterpart, and they can see it from their station in our office can see it and do it. So we decided obviously to build on that because we haven't seen it in our practice. We had a very practice in one of our clinics. We had over 300 radiology studies we did a day. That is really busy. And it was chaotic. We didn't have that kind of system like this one. So we definitely want to take it to the healthcare industry, and we want obviously to, we're going to take it next to be a pure cloud as well. And we, as I said, we will expand that workflow concept to engage with the patients and engage in the other areas like the business side of it with for healthcare.
Great. Well, thank you very much. So, Dr. Raghu, your closing comments?
You know, with all this EHR movement and meaningful use and all that, they're talking about interoperability. There are many companies out there in the world that have been doing a practice management and EHR portal, and they've all been doing good jobs at their thing. What's happening with a lot of these big vendors, these huge hospital vendors, they're gobbling up all the little good guys, like the private practice, and forcing people to use their all-in-one systems, which may not be good. I look at Excite Health. it's like after my stethoscope, that's the next medical piece of equipment that I use. It's the hub for where everything comes together and happens for us. It's basically revolutionized RBK Pediatrics, put us on the map, and you know what? We're not going to be taken over by a hospital system, a network, or anybody.
Great. Well, thank you for that. And last but not least, Dr. Chuck Webster, your comments.
Thank you. I'm glad you added not least. I grew up on the banks of the Mississippi River on a farm that was homesteaded in the 1800s, and every spring we watch the river. It's frozen, and then it finally starts to break loose, and then you see the volume coming down. I see healthcare IT as a little bit like that frozen river. I often talk about frozen workflows, but I also see a spring, and I think things are about to break up. Every year I look at every HIMSS exhibitor website and I search for workflow. 2 years ago, 8% had it in their technical documentation or marketing. 16% last year. I'm thinking it's going to be 33%. And here I'm talking about customizable workflow, workflow analytics, workflow editors, coming thing. And finally, social media is incredibly important to the educational part here. And I'd like to thank everybody who has showed up from Twitter, for example, and I have learned so much from you. And social media, I think, will be the way both, and even Facebook and so forth, we need to get all the birds of a feather to band together and bang the workflow drum so that everybody else hears and joins the parade.
Super. Well, thank you all for participating today. Thanks to the audience for some fabulous questions, and we look forward to hearing your progress as you move forward. So everyone have a great day, and thanks for attending the webinar. Take care.
Thank you very much.
Thank you. Bye-bye.